All right, we're going to switch to the order of the last two. Next is Erica. She gets to give the fun talk, actually, because I think I've always been interested in visceral artery aneurysms. We get to meander all over the place, but they're also pretty challenging. So, Erica.
Afternoon, nearing the end of your day. Oh, good, I have my glasses. I'm going to be talking to you about the management of visceral artery aneurysms, including renal artery aneurysms. And got to figure this out as usual. All right. So since we are at Methodist, I think it's important that you understand that the first visceral artery aneurysm was repaired here, DeBakey and Cooley. And I clearly need my glasses. All right. So in terms of visceral artery aneurysms, we're going to go over epidemiology, and then we'll go over the symptoms and management and complications. So if you look at visceral artery aneurysms, the most common that you will see in your lifetime is splenic, followed by hepatic. But understand that they are rare, so these aren't something that you're going to have series or cases of in your practice. And usually these are referred to academic institutions. In terms of artery aneurysms, I think it's important to understand that visceral artery aneurysms include both true and pseudoaneurysms, and that they are, those with pseudoaneurysms do have higher risks of rupture, and therefore they are usually indications it's always for treatment for pseudoaneurysms, even at a smaller size than a true aneurysm. In terms of risk of rupture, they depend on the aneurysms that present, but most commonly there's a higher risk for hepatic artery aneurysms. And then the aneurysms at high pressure, so those that's in small vessels, and we'll go over this, but the reasons that they're under high pressures is that there's a celiac artery stenosis, but these aneurysms are usually thin-walled and have a higher rupture rate, so these are generally repaired at even small sizes, less than 2 centimeters. In terms of splenic artery aneurysms, the prevalence, like I said, it is the most common. They are more frequent in women, particularly in the childbearing years, and that's primarily because of the hormonal influence, relaxin. No one really understands, but there is that clear association. And then they are common with portal hypertension when there is hepatic congestion. If any of you have done portal vein reconstructions, you'll see that the splenic vein comes in that region. And if there is portal hypertension, you can see that the venous system and therefore the arterial system is under pressure. In terms of presentation, most of aneurysms are now found incidentally. If you think about everyone gets a CAT scan, the ABCs of the ER are assessed from the door, back away, get a CAT scan. This is how they're made. The diagnosis is made from incidental CAT scans. Occasionally, patients will present in a ruptured state, and if it is a splenic artery aneurysm, they can be protected in the sense of the double rupture. That's the first rupture into the lesser sac, followed by the second rupture into the free peritoneum. And mortality rates obviously are higher if they rupture, and clearly much higher in women that are pregnant, especially if you are in your 3rd trimester with a large gravid uterus. Indications for repair are generally greater than 2 centimeters, particularly in women of childbearing age. Usually, if you do find an aneurysm in these women, you'd repair it prophylactically, even if it is smaller than that. And then complications of treatment, especially for open repair, would be pancreatitis. If you remember, the splenic artery travels behind the pancreas. And we all learned in residency, don't F with the pancreas. And then with endovascular repair, complications usually are splenic infarction. So in terms of operative repair, it depends on the ease of operation, depends on where the splenic artery aneurysm approximately. And middle aneurysms, you can just ligate proximal distal. You can remove the aneurysm if necessary. You can perform it laparoscopically. But I'd say most people defer to endovascular repair if you can because of the ease to the patient and the ease to the surgeon themselves. So obviously, if it's easily accessible, you can remove it. If it's not, if it's embedded in the pancreas, then you just ligate it. If it definitely is embedded here, you can either remove just the spleen or do a distal pancreatectomy. Hepatic artery aneurysms are, again, rare. 500 cases reported in the literature, so if you come across this in your training, you're lucky. Most are related to trauma in the young patients, and you do see these commonly with intrahepatic aneurysms. And non-trauma is usually elderly patients. Risk factors are atherosclerosis, connective tissue disorders, trauma, infection. And then I have started to see more dissections and aneurysms related to endovascular interventions, especially in the setting of chemotherapy for hepatic tumors. And obviously treatment depends on where they are. So oftentimes a presentation can be triad of kinky, no, that's not how you pronounce it, but abdominal pain, hepatophilia, and obstructive jaundice, and that's when you obviously have a connection between the aneurysm and the artery and the biliary system. In terms of repair, obviously anyone who presents with rupture is going to get repaired, and anyone with symptoms. Elective repair is usually for those of greater than 2 centimeters or in the setting of FMD. Complications obviously depend on where the aneurysm is itself and what the treatment is. So in terms of operative repair, remember the common hepatic artery is common to the hepatic artery and the GDA, so that's the first part of the hepatic artery. Proper hepatic is common to the right and left hepatic arteries. So repair depends on where they are. If you have a good GDA in this area and good retrograde flow into the liver, you can ligate it. But obviously when you have an aneurysm in the proper hepatic, you have to repair it or bypass around it because otherwise you'll compromise the blood supply to the liver. And then if it's within the liver itself, endovascular repair. And of course, that would be coils or particle embolization. In terms of celiac artery aneurysms, even rarer, 5% splenic artery aneurysms, splenic artery aneurysms. And these are often found in association with aortic aneurysm, and more common in men. Historically, they were found in patients with syphilis, but syphilis has kind of gone away in the setting of penicillin. But the etiology can be from collagen vascular diseases, dissection, trauma, and infection. Again, when these rupture, you can have that double rupture since they are behind that, the lesser sac. But the mortality rate is high just because when you think about it, when these patients present, even in the setting of a ruptured abdominal aortic aneurysm, it's kind of hard to get to the celiac artery. It's much deeper than you imagine. In the cases of rupture, like I said, you can have that double rupture. In terms of repair, obviously anyone presenting with rupture, indication is repair. And in our institution, we elect for elective repair greater than 1.5 to 2 centimeters, depending on the state of the patient, especially in the area of endovascular treatment. In terms of operative repair, ligation is reasonable if you have a patent SMA and you have a good GDA. So you can ligate the artery right at the origin of the celiac artery. And bypass is necessary if you do have stenosis of the SMA or poor flow through the GDA. And obviously now, if these patients are suitable for endovascular repair, most people would elect for that as a first option. When patients present with SMA artery aneurysms, you have to think of infection. Predominantly, these are mycotic, and you have to think of endocarditis or some kind of bacterial endocarditis. So the first thing you need to do is put them on antibiotics and then work up, get an echo, work them up for endocarditis. Other causes obviously are connective tissue and atherosclerosis, as well as settings in false aneurysms in the setting of pancreatitis. Clinical findings, these patients generally present with malaise, general symptoms of illness from endocarditis, and they can have abdominal tenderness. That's clearly how we've seen presentations at our institution. And then if they rupture, the high rate of mortality, because if you think about it, if you knock out the perfusion to the small intestine, that's the end of your life. All should be treated regardless of size. So if anyone presenting with SMA aneurysm should be fixed. Obviously, you need to figure out what the etiology is and treat the underlying causes as well. So antibiotics, look for cause, remove the aneurysm. If it's infected, you wouldn't want to place a stent graft, and you have to bypass to preserve perfusion to the small intestine. Now we're getting on to really obscure aneurysms, so pancreaticoduodenal and gastroduodenal. Like I mentioned earlier, most of these are pseudoaneurysms, and they arise in the setting of high pressure in these vessels, And usually that's in the setting of pancreatitis, chronic alcohol use, and injury to the biliary tree, and it's sort of inflammation of the pancreas itself. You can get true aneurysms in the setting of median arcuate ligament syndrome, as well as celiac artery stenosis with poststenotic dilatation and pressure and high pressure in that region. So clinical findings and diagnosis is pretty nonspecific: abdominal pain radiating to the back, and if you think about it, that's presentation of pancreatitis. And unfortunately, these, what we've seen in our institution, they have like a small rupture in that region. They present, and then you've got to figure out what it is. So most of these patients really need a good angiography to determine what the vessel is that they're rising from and how you can manage it. So indications for treatment obviously are anyone who presents with symptoms in the presence of the aneurysm itself because of the high propensity for rupture. And then treatment, most people would go for coral embolization or percutaneous thrombin injection, or in the setting of if you already open up the patient, it can be very, very challenging. And then even more obscure aneurysms, these are aneurysms arising off of the gastric artery or the gastroepiploic arteries themselves. The etiology is multiple, so degenerative disease, traumatic, and inflammation, and generally are in elderly men. Clinical findings, once again, pretty vague abdominal pain unless they present with rupture, and that's hypertension. And then the indications for treatment are all aneurysms, once again, because these are small, thin-walled vessels with a high propensity for rupture. And then operative repair, if they present ruptured and you open the abdomen, you've got to find it, which can be pretty difficult. So once again, a preoperative angiogram is very helpful. Finally, the sort of final of the colonic or intestinal aneurysms are the small vessels providing blood supply to the jejunum, ileum, and the colon. So these are far out in the vascular tree. They're extremely rare, and really defining what branch vessels they arise from, if you can coil them or embolize them, that would be helpful, because you could take, and keeping in mind that embolization may result with necrosis of that small portion of bowel, so these patients do have to be observed carefully postoperatively. And indications for repair is really the presence of them because of the risk for rupture. And then, like I mentioned earlier, angiography is important to help delineate where they come off the vascular tree, whether you can treat them endovascularly or if you have to just resect that portion of bowel that is perfused from that portion of artery. Renal artery aneurysms, 20% of visceral artery aneurysms, they're rare. They are bilateral, so you have to look at both the right and left, just make sure you're not missing on the other side. Etiologies are FMD, as mentioned by Guillermo, atherosclerosis and arteritis, and they can be associated with other clinical conditions like hypertension. No one really knows whether it's the aneurysm that causes the hypertension or the hypertension that causes the aneurysm, but there's clearly a correlation between the two. And then you can have renal insufficiency, and in these patients look for other aneurysms as well. So most of these patients are asymptomatic. They present with, this is found in just independently of symptoms, just with a CAT scan. And then some of these patients do present with hypertension. If you're working up FMD or if you're working up severe hypertension, obviously you'd be doing imaging studies to delineate it. And also the workup of hematuria would also rule out an aneurysm as well. So ultrasound, you start with the ultrasound and the CTA. Risk of rupture is low, but does increase the mortality rate if not fixed electively. And of course, the risk is higher in women because of that, the effects of the hormonal effect. So indications for treatment, most people would say any aneurysms greater than 2 centimeters in size, but remember you have to consider what the patient's overall condition and age and whether it's open or endovascular repair depending on where the aneurysm itself is located. So if you look at the aneurysm, if the aneurysm is located in the main renal artery or anteriorly, they can certainly be repaired endovascularly or with an open approach. with either bypass around it or removing the aneurysm off the artery itself and patching the artery with a vein patch. And obviously, if someone presents ruptured and hypertensive and near death, then you would just remove the kidney itself. For distal renal artery aneurysms, when you start getting into the segmental branches or you at a branch point within the kidney itself, these are patients that need ex vivo repair. So you'd remove the kidney from the body itself. It's usually wise to have a transplant surgeon working with you, and then you can repair the aneurysm and then replace the kidney. And then for endovascular repair, depending on where it is in the main branch or here, these you can just graft across, and if you start getting out into the branches, you have to accept that you're going to lose part of the kidney to repair these or exclude these aneurysms. And so finally, just the treatment of splenic artery aneurysms. In my 11 years since training, I've definitely seen an evolution from open to endovascular repair. I'd say most people would do an endovascular repair first if possible and reserve open in the setting of infection or rupture, or if endovascular options aren't suitable depending on the anatomy. All right.